So today we'll be looking at hemodynamic monitoring, which is a very familiar terrain for us as anesthetists. And we're just going to go into some of the basic principles of the common hemodynamic monitoring parameters that we are quite familiar with. So we'll go through this outline introduction. We'll look at indications for hemodynamic monitoring, general hemodynamic monitoring, blood pressure, both direct and indirect, central venous pressure monitoring, pulmonary artery catheter insertion, and pulmonary capillary wedge pressure monitoring, cardiac monitoring or measurement, and we'll conclude. Our monitoring, as we know, is very important in our practice as anesthetists and critical care physician. And there are different parameters that we monitor, and we're looking at hemodynamic monitoring in today's lecture tutorial. So hemodynamic monitoring is a vital aspect of monitoring in anesthesia and critical care, like I mentioned, and it involves monitoring the blood pressure, the central venous pressure, pulmonary artery occlusion pressure, pulmonary capillary wedge pressure, and we look at cardiac output measurement. These are the common components of hemodynamic monitoring. Yeah, hemodynamic monitoring generally can be done with the IPPA that we're familiar with. It starts with inspection. You want to look at the anterior chest wall for hips and increased visible pulsations. Sometimes we call it active precordium. We can just inspect and see, all right, for obvious hips and increased visible pulsations. You also want to palpate, especially along the point of maximum intensity of the heart. All right, and a lot of times when we're in school, we're made to locate the apex beat. Then you want to percuss, all right? And percussion actually starts from side to side and top to bottom. We can see the pattern that is illustrated in the diagram above. All right, so importantly, you need to compare side to side looking for asymmetry. All right, then you want to auscultate, and there are different auscultation areas: the aortic, the pulmonic, the second pulmonic mitral, and tricuspid areas of the precordium, as you can see here. So following the IPPA, you want to inspect, you want to palpate, you want to percuss, and you want to auscultate. All right, so generally, this is a lot of times, this is where hemodynamic monitoring must start from. So talking about the blood pressure, we're talking about blood pressure monitoring. By way of reminder, we know that arterial blood pressure refers to the pressure measured in the large vessels. And this is the pressure that moves blood around the systemic circulation. It's comprised of two components, the systolic and the diastolic pressures. All right, and the normal arterial blood pressure for an adult, as we know, is around 120/70 millimeters of mercury. One thing I always like to ask people is what is pulse pressure, which is the difference between systolic and diastolic pressure, which can actually give us a lot of information about the hemodynamic status of the patient. Another very important component of blood pressure measurement is the mean arterial pressure, all right, which is the perfusion pressure for the organs. And it's given as diastolic pressure plus 1/3 pulse pressure, which is systolic minus diastolic pressure. So it's easier, to write MAP as diastolic blood pressure plus 1/3 pulse pressure. All right, and pulse pressure is what I have just defined above as the difference between systolic and diastolic pressure. So blood pressure can be measured either by indirect or direct means. And there are different indirect ways of monitoring the arterial blood pressure. And I wrote PATOD, all right? And it means palpatory method. So indirect blood pressure method can be done by palpatory method. And what does this involve? Is a method of measuring only the systolic blood pressure. With palpatory method, you only measure the systolic pressure. And this responds to the first arterial pulsation that you feel after inflating a blood pressure curve, all right, while placing your hand or your finger on the radial artery. So the first pulsation that you will feel while palpating the radial artery after you have inflated the blood pressure curve above systolic, that is the systolic blood pressure. Tonometry is one way of indirect blood pressure monitoring, and this makes use of a pressure transducer that is positioned over the radial artery. All right, the transducer output is measured, and the voltage is proportional to the blood pressure, which is displayed as a continuous trace. So the blood pressure is taken as the transducer output voltage. Oscillometry, this is another important indirect method of blood pressure monitoring, and it uses two curves, one for occluding the brachial artery and the other one for detecting pulsation. So two curves, one occludes the brachial artery and the other detects pulsation. An example is the von Requerhausen oscillometer. All right, the upper curve is about 5 centimeters wide, while the lower curve is about 10 centimeters wide. So the first curve is for occluding the brachial artery, while there's a sensor on the second curve that detects when pulsation begins to come. The fourth one is the auscultatory method. All right, this is what we commonly use with our amyloid or mercury manometer. All right, this detects this uses the detection of brachial pulsation via the Korsakoff sounds. All right, this sound is detected by a pulse detector, all right, or a Doppler probe. So you hear the Korsakoff sounds as it's amplified by your pulse detector, your Doppler probe. The mercury manometer, your anaeroid manometer, is attached to a curve which is inflated around the upper arm until the brachial artery pulsation disappears. And you know how it goes. You slowly reduce it and you start hearing the first sound, which corresponds to your systolic. And when the sound disappears, which corresponds to your diastolic. All right, the second way of monitoring the blood pressure is the direct method, the direct or invasive method. All right, and invasive, all right, requires arterial cannulation. All right, and a lot of times, when you ask what are the indications for direct blood pressure monitoring, you want to talk about regular sampling for analysis of your ABG. You put an A line, which you can also use for your direct blood pressure, beat by beat measurements of your blood pressure. When you have large intraoperative blood swings, all right, especially when it has to do with massive blood loss and blood pressure swings very significantly, you want to do a beat by beat measurement of the blood pressure. Sometimes it's used when non-invasive blood pressure is unreliable, especially in cases of the morbidly obese patient. Sometimes when you can't get appropriate cuffs, BP cuff for the patient. Direct blood pressure monitoring is also indicated in cases of elective hypotension or deliberate hypotension, okay? End organ diseases, patient with end organ disorders or diseases. And you also want to do continuous cardiac output monitoring, which is possible with observation and monitoring of your arterial waveform. And sometimes when you have crush injuries to the limbs, and it's impossible for you to just put a curve around it, or you do not want arterial insufficiency at any point where you are doing your inflation. So these are some of the indications for direct blood pressure monitoring. Contraindications: you don't cannulate an artery without collateral circulation. And in patients that have vascular insufficiency, you don't want to put a catheter in those vessels. As an example, are patients with renal phenomena. All right, the components of direct blood pressure monitoring. Number one, you need a cannula with an indwelling Teflon catheter. You need a connecting catheter. We all know this. It's just to remind ourselves. There are a lot of connectors. Importantly, you need a column of bubble-free heparinase saline, which is under pressure, especially around 300 millimeters of mercury for flushing. You need a diaphragm, which acts as an interface between the transducer and the column of bubble-free fluid. So the next step is to do your arterial cannulation. Importantly, you must do your alien test to confirm collateral circulation of the radial artery. And in the foot, you can do modified alien test. All right, you want to get a heparinase saline about 3 to 5 ml available, dosiflex the patient's wrist. We all know this. You obtain a skill wheel and you put your catheter at an angle, a cannula with a Teflon catheter at an angle of 5 degrees. Yeah, as good as direct blood pressure monitoring may be, it's not without complication. It can cause arterial thrombosis with loss of perfusion to that limbs, especially those without collateral circulation. You can have occult bleeding. There could be cerebral embolization from blood clot form. You can cause localized infection, which may spread to septicemia. And recently I heard of a case where intravenous antibiotics was actually administered through the A-line, which resulted in catastrophic outcome. Mechanism of action: the column of saline moves back and forth with arterial pulsation, and the diaphragm moves with each pulsation, which causes a change in resistance and current flow through the transducer. This change in resistance and current flow is measured through the Wheatstone bridge, if you remember physics, where it calculates the resistance and the current, and you're able to get the current flow from the changes in resistance 1, resistance 2, we remember that. So the changes in resistance and current are now measured electrically, all right, through the transducer, and these are converted to your systolic, diastolic, and mean arterial pressures. All right, so this is a diagram just to show you the components of a direct blood pressure monitoring and how it works. This is the column of your bubble-free heparinase saline, which is under pressure, about 300 millimeters of mercury, okay? And this is your transducer that is placed here, close to the heart of the patient. And you have your Teflon catheter inserted into the radial artery. And you have your monitor. This is your flushing device to ensure that there's no blockage. So this is your monitor, all right, that converts the electrical and resistance, the electrical current flow and the change in resistance at the Wheatstone bridge, which is connected to the transducer, which is displayed electrically on the monitor. All right, and when you see on the monitor, you see the arterial waveform, which is what we see here. All right, we have the systolic upstroke, we have the systolic peak pressure, then we have the systolic decline, and you have your dichrotic notch, and you have your end diastolic pressure. There's a diastolic runoff here. And all these components All these components are important because they give you very important information about the hemodynamic status of the patient. Okay, these are popular exam questions. I can ask you, draw this without all this labeling and ask you to identify this waveform. And ask you to label the different parts of the waveform. And I may ask you, all right, under this arterial waveform to give me the relationship between peripheral vascular resistance and the dichrotic notch. And the fourth question under this may be myocardial contractility is represented by what? All right. So these are very familiar questions, and it's good for you to just familiarize yourself with it. So the arterial waveform I've been showing you is actually characterized by a complex sine wave, which is a summation of a series of simple sine waves of different amplitudes and frequencies. The first thing you will note that we want to talk about is the dichrotic notch, all right, which represent changes in pressure due to the closure of the AV valve, all right, the atrioventricular valve, all right. And this dichrotic notch is very important because it gives you two vital informations, the peripheral vascular resistance, all right, and the position of the dichrotic notch on the downstroke represents peripheral vascular resistance. All right, the position is low, the dichrotic notch is low, all right, in vasodilated patient and is higher in vasoconstricted patient. So the position of the dichrotic notch on the downstroke represents whether the patient is vasodilated or vasoconstricted. Let me go back to it. All right. Now, this is a position. This is the systolic decline. Okay, this is systolic decline. So you can see from here that if it's lower down, if the dichrotic position of the dichrotic notch is lower down, it represents a patient who is vasodilated, which you can see especially in septic patient. Well, if it's higher up, you can see that the patient is vasoconstricted. So it is actually around about 2/3 of the systolic upstroke. Anything lower or higher represents an abnormality. Okay, myocardial contractility is represented by the rate of rise of the upstroke, and which can actually give you an indication of response to your inotropic support. When you put a patient on inotropic support or a vasopressor, for instance, the rate of rise of the systolic upstroke will indicate, the response to your inotropic support. All right. If the rise of the upstroke is slow, all right, this is the upstroke. If after you inserted your A line and the rise is slow, is an indication for you to put the patient on inotropic support. However, it also, once you put it and there's good response, you can see that the upstroke will be steeper and the rise will be faster, showing a positive response to your inotropic or vasopressor. All right, from the arterial waveform, you can calculate the stroke volume, which can be measured, all right, that can be estimated by measuring the area from the beginning of upstroke to the dichrotic notch. All right, the beginning of upstroke. All right, this is the beginning of upstroke to the dichrotic notch. This will give you the systolic volume. The beginning of upstroke to the dichrotic notch. That will give you the stroke volume. Resistance, this is caused by a stiff resonance, This is caused by a stiff and non-compliant diaphragm and tube. All right. Sometimes when you have elevated blood pressure on your systolic, on your A line, you want to be sure that it's not due to increased resonance, because increased resonance will cause a precipitous rise in your systolic blood pressure, and it will lower your diastolic blood pressure. So you want to ensure that they have optimal resonance in the system. Damping may be due to the collection of air in the catheter transducer system, and increased damping will lower your systolic blood pressure and elevate diastolic blood pressure. So this is a common MCQ or single best answer question. Increased resistance elevates systolic blood pressure, lowers diastolic blood pressure. Increased damping causes opposite, lowers systolic blood pressure, increases diastolic blood pressure. Apart from the presence of air in the catheter transducer system, other causes of damping include clot formation, and when the system is highly compliant, maybe the diaphragm is too soft, which is the interface between the transducer and the Teflon catheter. The second hemodynamic parameter that we often measure in anesthesia and critical care is the central venous pressure, all right, CVP. Now, this refers to the venous pressure in the right atrium, and is also equal to the pressure in the great vessels of the thorax. All right, it is the diastolic filling pressure of the right ventricle. It is a value that is measured at diastole, and the normal value of CVP is between 0 to 8 centimeters of water. Indications of central venous pressure measurement includes administration of fluid, all right, or aspiration of air embolism. So I put it at a CVP. All right, you want to use it to measure central venous pressure, all right, especially to also guide your fluid administration. For vasoactive agent administration, you remember from what Tonata was presenting when she was asked about adrenaline, how the route of administration and all that. And regular venous blood sampling, I actually say that every patient that was staying more than 24 hours in the ICU should have a CVP. And one of the reasons for regular venous blood sampling. You can actually do your pacemaker insertion through your central venous catheter already inserted, and parenteral nutrition can also be given through your central venous catheter. And sometimes you have patients who is completely bond and there is no peripheral line. Your CVP in this patient is indicated. Contraindications, infection. If there's infection at the site of surgery, you have neck masses, or a patient has recently had a neck surgery. Coagulopathies, all right, carotid disease. And when you have contralateral diaphragmatic dysfunction, you want to avoid setting a central venous pressure. Patients with vena cava syndrome, a patient who already had a pacemaker inserted, you don't want to put a CVP on that same side. Complications arise from, the insertion of the procedure, all right, even during monitoring and all that. So a CVP is also the mnemonics, anterior puncture, all right, depends on the route, all right, you can do a carotid, you can do femoral, you can do subclavian arterial puncture, and that will be catastrophic, especially for your subclavian route, when it will be difficult for you to compress. You can cause the embolism if you do not do proper position, head-on position. You can introduce chest infections. You can actually cause venous thromboembolism, and pneumothorax is with common complications of citing the central venous catheter. And that's why it's important that immediately after citing your central venous catheter, you obtain a chest X-ray And one of the reasons you do that is to rule out a pneumothorax. And you can actually have hemo or hydrothorax as a complication of central venous catheter insertion. Now, apart from the other ones, very importantly, especially if you're transducing your CVP waveform, it can actually give you a lot of information, okay? A CV waveform consists of 3 peaks, the ACV, and 3 descent, the SY descent, all right? And these different peaks and descents result from the ebb and flow of blood in the right atrium. The A wave, as you can see from here, the A wave, is used to increase atrial pressure from the contraction of the right atrium, and is, corresponds to the P wave on your ECG. So the A wave on your CVP waveform actually corresponds to the P wave on your ECG, which is represents atrial contraction. The C wave is a slight elevation, okay, all right, and all right, a slight elevation into the right atrium during earlier ventricular contractions, okay, and this represents your, excuse me, your QRS complex, all right. So your C wave represents your QRS complex. The S descent. The S descent is caused by the downward movement of the ventricle during diastole, all right? And this occurs before the T wave on your ECG. The V wave, the last upstroke or the last peak represents, arise from pressure due to blood filling the right ventricle, all right, when the tricuspid valve is closed, okay? So the V wave arises from pressure due to the blood filling to the right ventricle when the tricuspid valve is closed. This happens at the end of your T wave. The Y descent is caused by the opening of the tricuspid valve in diastole, and this occurs before the next P wave. So these are very important, informations that you can get from your CVP waveform, especially if it's transduced. The A wave is the arterial contraction, which corresponds to the P wave on the ECG, all right? And the C wave corresponds to QRS complex when the tricuspid valve moves into the right atrium during early ventricular contraction, and you have this S descent, which corresponds to the atrial realization and downward movement of the tricuspid valve during systole, ventricular systole. These are very important. And the next slide will show you some pathological CVP waveforms that, once you see them, it gives an indication of what's going on. Just like the absent P waves, when there is atrial fibrillation, the A waves on the CVP disappears. All right, you see Cannon waves when there's AV, atrioventricular dissociation. All right, what it means is that you have increased A waves in terms of what's it called, amplitude. All right, tricuspid valve regurgitation. Now, this will give you a positive wave of regurgitation, which replaces the C wave and the S descent. In case of cardiac tamponade, which is a cardiac emergency, which can occur in different scenarios, all the pressures are elevated, all the pressures, the A, C, V waves are elevated, but importantly, you will see an absent wide descent. So in cardiac component, there is loss or absent wide descent, while in atrial fibrillation, you see absent A waves. All right, so there are questions on the right side, practice questions. What are the indications for central venous catheter or central venous pressure measurement in the operating room? mention at least 5 contraindications to CVC, and draw and label a normal CVP waveform. And I may add some pathological CVP waveforms. I may ask you to interpret what these pathological waveforms mean. Are you still together? Are you still with me?
Yes, Prof.
Okay. All right, so let's go to the next parameter that we'll talk about. So the pulmonary capillary wedge pressure. I remember those days in our training, they will bring a pulmonary catheter for us to identify and to describe the different types. Okay, the components of the common pulmonary artery catheter, you have especially the 5 lumen, you have the lumen, the proximal lumen, which is for injection of code injected, all right, injection, not infection. You have the lumen for your thermistor, which is to measure core temperature, all right, which is useful for cardiac measurement. The third lumen is known as balloon lumen, which is inflated during the measurement for the capillary wedge pressure, also known as pulmonary arterial occlusion pressure. Then we have the 4th lumen, which is reserved for infusion of fluids and blood products, as the case may be. The distal, which is the 5th lumen, is for capillary wedge pressure measurement and sampling of mixed venous blood. All right, so for a 5 lumen catheter, pulmonary artery catheter, you need to familiarize yourself with each of these 5 lumens and what they are used for. All right. So what are the indications? Recently, a lot of passing a pulmonary artery catheter has fallen into disfavor because there are other parameters, there are other ways you can monitor and measure the parameters that a pulmonary artery catheter can measure, and it's more technical and it's fraught with increased complications. So passage of pulmonary artery catheter is not the darling of many critical care physicians. However, it's important for you to familiarize yourself with it. And the indication, for instance, is POP, pulmonary occlusion pressure. By now, I'm sure you know that I like lemons. So POP, PAOP, pacing wire passage. All right, patients, especially in acute respiratory distress syndrome. This is important because the definition of arterial acute respiratory distress syndrome has to do with pulmonary capillary wedge pressure. All right, once you measure pulmonary capillary wedge pressure and it's less than 18 centimeters of water, and there are indications for severe hypoxemia, all right, and respiratory failure, that is acute respiratory distress syndrome. So the value of the pulmonary capillary wedge pressure, which is measured, with the use of your PAC, was cardinal to diagnosis of ARDS. Patients with oliguria, pressure low in shock, all right, for instance, in cardiogenic shock and septic shock. These are some of the indications reserved for passage of pulmonary artery catheter. Now, so let's talk about the pulmonary capillary wedge pressure I mentioned before. All right, the pressure, this is the pressure within the pulmonary artery system, all right, which is measured during pulmonary artery catheterization. And the tip of the catheter is wedged between the tapering branch of one of the pulmonary arteries. That's why it's called pulmonary capillary wedge pressure. All right, the pulmonary capillary wedge pressure represents left ventricular end diastolic pressure, which is an indirect indicator of ventricular end diastole and myocardial fiber length. Let me come again. The pulmonary capillary wave pressure represents left ventricular end diastolic pressure, all right, which is an indirect indicator of ventricular end diastole, and it also indicates the myocardial fiber length. All right, why we do this is that the pulmonary capillary pressure is an indication of likelihood of edema formation, all right, especially during in the face of normal pulmonary permeability. So know that, like I mentioned for ARDS, the edema that is seen, all right, that is seen with a PCW less than 18 is due to abnormal pulmonary vascular permeability. All right, so if the PCWP is less than 18, all right, and there's evidence of acute respiratory failure with severe arterial hypoxemia, all right, and you measure your PCW and it is not a cardiogenic shock, all right, it shows that this is ARDS. For cardiogenic shock, the PCWP will be more than 18, but if it's less than 18, and there's evidence of respiratory distress, respiratory failure with hypoxemia, all right, it shows that the edema is not of cardiac origin, because PCW, increased PCW, it shows pulmonary edema in the face of normal pulmonary permeability. So indications, like I mentioned before, the guide to intravascular fluid status, likelihood of pulmonary edema formation, and values greater than 18 shows pulmonary edema of cardiac origin, okay? Now, each of these waveforms can be transduced, just like the central venous pressure, and you can see here, all right, it resembles the venous waveforms with A and V wave, and it swings with respiration. So the A wave and all that is similar to the central venous pressure waveforms. All right, so we'll look at cardiac output measurement, which is important a lot of times, especially during cardiac procedures. And there are about different ways of, in fact, there are newer ways. I want you to just brush up, but the common ways are the FEDECO, I call it FEDECO. Number one is the Fick's principle. All right, Fick's principle is number one way of cardiac output measurement. And Fick's principle states that the blood flow to an organ per unit time is equal to the amount of a marker substance injected into the circulatory that is taken up by the organ per unit time, which is divided by the concentration difference of the substance in the atrial and venous blood. So once you inject the marker substance and you measure it, all right, the blood flow is the amount of the substance that is taken up by the blood divided by the difference between the arterial and venous concentration of that marker substance. So this is used to measure the cardiac output in critical care settings where an injectable, a marker substance is injected, and you measure it, you collect the venous concentration, the mixed venous blood, and you're able to calculate, all right, the amount of substance that you injected over the arterial venous difference. That will show you the cardiac output, which is measured. The second way to measure cardiac output is by echocardiography, which can be either transthoracic or transesophageal. Transthoracic is common, but intra-op, especially during cardiac surgery, you can have transesophageal, all right? And transesophageal is important because it gives you the movement of the anterior and the posterior ventricular walls, and also gives you a measure of injection fraction. All right, the stroke volume is derived by relying on the shape of the ventricular activity. Okay, so echocardiography is one way to measure cardiac output. The third one is the dilution techniques, which can either be dye dilution technique or thermodilution technique. In dye dilution technique, you inject a no amount of dye into the pulmonary artery, and you measure the concentration peripherally using a photoelectric spectrometer. The commonest dye that is used is the indocyanic green. Because of its low toxicity, it has a short half-life and a very favorable absorption characteristics, and it is not affected by changes in oxygen saturation. So what you do is that the cardiac output is calculated from the injected dose by calculating the area under the curve within the extrapolated line and its duration. Curves of short duration are produced by high cardiac output, and those with long curves are produced by low cardiac output. It will be good for you to familiarize yourself with this curve. Unfortunately, I don't have it on this slide. I can provide it for you before I send this slide to you. An alternative to indocyanic green as a dye injected is lithium. Lithium can be used, but lithium is injected via a central venous catheter, and you measure the peripheral concentration of lithium by using the lithium sensitive electrode, which is incorporated into an arterial cannula. So this is that dilution technique for measurement of cardiac output. The thermodilution technique, it uses cold injected, okay? And that's what we use. You remember when we're talking about pulmonary artery catheter, the first lumen is for the injection of cold injected. So you put 5 to 10 ml of cold dextrose or saline through the proximal port of the pulmonary artery catheter, and you measure the temperature changes by the thermistor, which is injected into the second lumen at the end of injection is actually at the end of expiration. So what you do is that you plot a graph of temperature drop against time, and use the Stewart-Hamilton equation to calculate the cardiac output. An average of at least 3 readings is used. You take 3 readings and you calculate the average, which gives you the cardiac output. All right, cardiac output requires cardiac catheterization, and these are some of the indications for cardiac catheterization. Other method is the esophageal Doppler for measurement of cardiac output. What does is that this follows the Doppler principle, which states that there's a Doppler shift in frequency when an ultrasound wave is reflected back from moving red blood cells. All right, and this shift in frequency is proportional to the velocity of the blood flow. All right, we know the Doppler principle. So esophageal Doppler measures flow velocity in the descending aorta using a flexible ultrasound probe that is passed through the esophagus. Now you use this. What just happened is that as ultrasound, all right, is being reflected back by the blood cells that are flowing, you can get the flow of blood from there, and you use it in combination with the cross-sectional area of the descending aorta to measure the cardiac output. And a nomogram based on age, weight, and height is usually used. All right, so cardiac output measurement, you can get the cardiac output, which is stroke volume times heart rate, all right? And the stroke volume can actually be calculated by measuring the stroke distance times the aortic root diameter. You can also get corrected systolic flow time and peak velocity and heart rate. All of this can be gotten from either of the different methods of measuring cardiac output. All right, so we have come to the end of the lecture, and as a way of recap, we've looked at hemodynamic monitoring, its relevance intraoperatively, its relevance in critical care setting. We have also looked at the different parameters that are measured or monitored. You know, we talked about blood pressure, which can be measured with two non-invasive and invasive methods. And I told you the different non-invasive method, the method that is palpatory, auscultatory, tonometry, oscillometry. All right. And I also mentioned to you the different indications for direct or invasive blood pressure monitoring and the components of how to do it. I've also mentioned to you central venous catheterization, which is used to measure central venous pressure, and mentioned to you the indications for passing a central venous catheter. I also did mention to you pulmonary artery catheterization, which is necessary for pulmonary capillary wedge pressure measurement. All right, it is also useful for cardiac output measurement. And I've also discussed with you the different waveforms, the central venous pressure waveforms, the pulmonary artery catheter waveforms. And I've also discussed with you cardiac output measurement, the indications for passing a cardiac catheter, and the different ways to measure cardiac output. So this question is cardiac output measurement is an essential component of monitoring in the critically ill patient. So as I mentioned, the different methods of cardiac output measurement and describe two of these methods. So